So say hi to you again. Now it's no longer GI physiology, but it's me now. Okay, the lower limbs. Okay, so we only got 5 lecture hours to talk about the lower limbs, and well, because of some unusual arrangement this year, so all these 5 lectures on lower limbs will finish in 8 days, Canada days. So you will see me next Tuesday, then done. Effective course, okay. So let's see what we can do to facilitate. I understand this is not really an optimal arrangement, but we will try to fix it next year. But literally, we only have 8 Canada days to finish all lower limbs, okay? So it will be a challenge to me as well. So that's why some of you asked whether I still have time to lunch just now. No, I just have 2 boiled eggs and that's all. No time. Okay, the lower limbs, so first we will talk about a bit of the overviews on the, about the osteology. So remember when we down to the dissection practical, so try to grasp the skeleton and take a look on the bone and all the bony landmark that are essential for your learnings. So the following are the lecture outcomes, the learning outcomes for this lecture. Let me highlight a few things to draw your attention, right? Since you are quite sleepy, I guess, because you all should be hypoglycemic now, okay, after lunch. So take a look on the blood supply of these femoral head and neck and its relevance to the avascular necrosis. Why I highlight this? Because this is actually a very severe clinical cases that we deal with on daily basis. Okay, so what makes these avascular necrosis so important? And then, and also how does it relate to the hip fracture and also the clinical implications? So what sort of treatment that the patient must receive? It's actually the short answer question last year, right? It should be, I can't remember, okay. And then, above all, the arterial anastomosis in the lower limbs is one of the big topics that we have to go for. Why? Think about it. We have to do different action. And different actions, different pattern of movement, whether you're running, whether you are uplifting heavy weight. So the blood supply to the lower limbs is of particularly important. And yes, because when you apply force, right, when you do some actions, certain areas may be under high pressure and the circulations may not be of usual as it should be. So that's why anastomosis is very important for the lower limbs. If I may say so, the upper limb will be more focused on the nerve. You take a look on your, can your toes do this action? No, never. Right? Maybe you can. But it's all the nerve, sensation, and also the motor functions, right? How delicate of these motion, right? The motor functions. But for the lower limbs, blood supply is one of the major concerns. Okay, that's all. So so starting from the lower limbs for these 5 lectures, I will give you 2 prompts, not the AI prompt. The prompt for you to think about what you should be able to answer or what you should know, at least have a framework how to answer these type of scenario-based questions. So there are old ladies, 75 years old ladies, sustains a fall, very common, and fracture her hip. Why is she at high risk of developing avascular necrosis, AVN? And why does the neck of the femur withstand the greatest stress in the lower limb, and what happens when this stress becomes too much? Okay, so let's think about it. Now then, back to the osteology. Well, you should know some of these osteology in your year one, right? In your year one. Then, so let's have a quick tour of the lower limbs. As you can see here is the thigh bone. So this is the thigh bone, okay, which is the femur. And then the two bones in the lower leg here, we have the tibia as well as the fibula. And then we have the bones of the foot, where we have the tarsal bones, we have the metatarsals, and also the phalanges. So this part is quite similar to the, with reference to the upper limbs, except the number of bones. Okay, so then we also have the bony frameworks here. So this is important because it is the basis for the movement, and also it carries the body weight, and it gives the limbs stability. So one note you have to pay attention to is the pelvis is not usually counted as the lower limb bones. It's called the girdle, right? But we will still review because it forms the hip socket, the acetabulum, okay? And it provides the attachment points for many muscles that move the leg, okay? So here, what you should take a look on is these transition area. So these are all the transition area, okay? So the main ideas is simple here. So when the blood vessels and nerves move from one region, say from here, then down to here, okay? From one region to another, they usually pass through a gateway. We talk about the gateway here, okay? So they are the key anatomical regions where structures like the nerve, blood vessels, and muscles passes between different parts of the lower limbs. So it serves as I said, serves as a gateway. So the first one here, which is the femoral triangle, so it's located in the superior medial thigh, and we will talk about it in lecture 2. So then at the back of your knee, we have a popliteal region, that is the popliteal fossa, which is a diamond-shaped depression behind the knee. We will talk about it in lecture 4. And then we also have a small but important one. So this one is called the tarsal tunnel. So the tarsal tunnel is located on the medial side of the ankle, so below the fascia retinaculum, and then we will talk about it in lecture 4 as well. So this one you can make it like for a reference as if we have here the carpal tunnel. Yeah, the carpal tunnel. You know the upper limbs and lower limbs are very comparable. So that's why we have Professor Song to give you a very comprehensive overview of the upper limb first, then I can just cut down to my 5 hours lecture. Good. So these are the areas, remember, of clinically significant, right? Each part. So think about these parts. It could be injury. It could be some problems and then lead to edema develop, or what we call the stab wound. Say, I remember 1 year, some times ago, there is a short answer question to have a scenario, like there is a chef, there is a stab wound on the femoral triangle, right? And then what will happen, which nerve damage or blah, blah, blah. I can't remember the question because it's not set by me, okay? So yeah, stab wound, it could be one of the way to make you understand, because these transition area, usually they are quite superficial and important structures passing through. So if there is the development of the high pressure insides, etc., etc. Okay, so we will deal with it one by one. And then back to the range of movement. So here is a quick overview. You should know it, right? Flexion. So if we go to this side, flexion, extension. And then for the hip joint here, if we move the leg, the thigh and the leg close to the midline, it is the adduction, right? Away from the midline, the abduction, okay? And then the same, if we stand on one limbs on ground and then exercise the muscles, right? So we can also have the abduction of the pelvis on the fixed femur as well, okay? And then also exercise the knee joint, we have the extension, and then we have the flexion. For the foot here, we have dorsiflexion, and then we have plantar flexion, okay? So, and one more here is we can take the internal rotation. So you take the kneecap, right, more to the midline. While for the external rotation, you take the kneecap, you take the whole thigh, the femur, right, laterally rotate a bit. Okay. But remember the range of movement in lower limbs is so different, right, from what we can observe in upper limbs. We want stability. Upper limbs want more flexibility, right? So, and then this one, if we have to turn these, actually this one should be called the all four together.乜都得係咪? Circumduction. So this one, the D, circumduction. And then sorry that I forgot to give you this image. Actually, you have this image as well because you can go to page 29. So we also have a unique structure, unique motions here called the inversion and also eversion. Now for the boys, if you play soccer or football game, sometimes you might have the outie, right? Very common, ankle sprain. So usually, in which way you will got the outie? Should be this one, right? Eversion. So remember this. Most of the time we have the eversion, E, instead of the I, right? So I will show you later why is it related to the anatomical arrangement, okay? So then now we talk about to support the upright standing. We are Homo sapien, right? You remember these scientific terms, Homo sapien. 什麼靈長類什麼唔知唔記得咩名 OK Homo sapien OK so to support the upright standing we all need to do so our femurs are directed downward and a bit toward the midline okay so that brings the knee and also the feet right close to the midline and it gives better stability for standing and walking. So now look at the numbered step to talk about the weight transmission process. So number one here, talk about the weight transmitted centrally down the vertebral column. And then further, when it go to the joint between the L5 and the S1, so that the force divided into two identically, right? By means of the bony arch, right, formed by the sacrum and the ala here. And this is the thick part here, number 3. So the thick portion of the ala here will transmit the force, right, to the femur. And then lastly, so the pubic rami form like a strut or brace that help maintains the integrity of the arch. So the force will down and then divide it into two, and then some will go down through here, and then it close the loop here, okay, at the pubic rami, okay. So that's why it explains why there is a great stress on the neck of the femur, because it serves, right, here as a bridge for weight transmission, right. This one should be between, not percentage, sorry. This one should be between the hip joint and the femoral shaft, So it narrowed structure with a smaller cross-sectional area must vary here a very central concentric force, concentrated force, making it a very valuable part. So that's why you, from time to time, you will hear like the old people, why it usually happen in female. Can you suggest a reason behind? Usually it's a female. Okay, so if something is a narrow bridge here, carry heavy load every day, so what happens when the material become weak, like as in osteoporosis? Women getting old, right? They may have osteoporosis, right? Because of the menopause. After the menopause, estrogen cannot keep at a good level, so that's why the bony mass may lose, right? Okay. So that's why I look at the case next time. When you see a case, usually we make the case, or I make the case, if you see female but not male, is it old enough? Very old. If there is a 4, then you should have osteoporosis in mind. It's actually very day to day, you can find these incident report in A&E department. Very common. Okay. So then talk about some, like here's the center of gravity, referring to the single point where the body mass is evenly distributed. So this is the COG, the center of gravity. So this center of gravity is slightly anterior to S2, okay? So in standing, it is slightly anterior or in front of the S2. So what is the line of gravity here, the LOG? If we can find the COG, then you draw a vertical line, then it passes slightly behind the hip, anterior to the knee, and also anterior to the ankle. Cool. So why we bother? Because it helps us stand with minimal muscle effort. Okay. So it creates a natural locks at all these joints, the hip joint, the knee joint, and also the ankle joint, so that we can help so our body weight can help maintain upright posture. So so this is why we have to learn a bit of this arrangement. Although we are not in physiotherapy. In physiotherapy, I taught more on this as well, but you just have a general understanding. So when you stand upright, so where is the COG? Slightly anterior to the S2. Okay, so that's why when some people, they may have some different abnormalities of the spine. So the COG may alter a little bit, right? So that's why it may make the effort that they have to play for like standing upright, they use up more energy, simply because of the posture is not naturally aligned, okay?點樣摸條骨嘅點樣？Which one you have first, the pelvic bones or the femur? Okay, pelvic. Okay, perfect. So this is so here you see the right hip bones in an anatomical position. So because I understand Dr. Wei already gave you a lot of ideas about the pelvics. So what I want you to observe is, remember these ASIS as well as the pubic tubercle. In anatomical position, these 2 points, let me highlight here. So these 2 points, they are all fall on the same vertical plane. Okay. And then another orientation point I want you to know is here. So in the acetabulum, we have the ball and socket joint. You know it very well. But for this one, the socket is deeper. And the ball is even more well-shaped, well-formed. So that's why it forms a better stability But in terms of the flexibility, sorry, either you cannot have both things happen at the same degree, right? So this one, we aim at more stability, okay? So that's why you see a more cup shape, and the head of femur, right, articulates inside it. Totally different story when you compare with the glenoid cavity. So this one is acetabulum, deep. And this acetabulum is formed by 3 bones together, okay? Okay? 哇！做乜突然間好熱啊？我 sorry 啊，我咪發燒啊！哎呀！ Okay, then we down to the femur. So femur, please note that, okay, this is Dr. Wang Weigai mentioned to you in your year 1. You should know that for every single long bone, there should be a head, neck, and shaft. Okay? So the head and the neck. So there are a few things that you need to know. This is the anterior view, and this is the posterior view. Take a look. Can you see any differences? So for the anterior view here, you only have the middle particular patellar surface, right? But at the back, you will have a more obvious contour, the condyle, right? And then at the back, can you see that there are some rough structures? So here, the upper part here, we call it the tuberosity. Remember the tuberosity? Right? Humerus got the tuberosity at the back. Okay? Here, we also have another rough part. So what for? Can you guess? Why we need to have some posterior part on the bone? Just for one reason, muscle attachment. So this one is called the linea aspera. We will touch on this later because several muscles attach on these linea aspera, okay? And what's more, the femur, anything else I need to tell you? I think that's all. So these are the greater trochanter and the lesser trochanter. So if you stand on one side and then you cross your leg like this, leg like this, and then you should be able to feel your own greater trochanter. If you can't do it now, tonight when you lie on the bed, you try to feel your own body landmark, your own body landmark, okay? Okay. Not your cat, your dog, okay? But one thing is that there are the trochanters, the greater trochanter, the lesser trochanter, and then I want you to see this line. This is the intertrochanteric line. Intertrochanteric line here, okay? Important landmark, later on we will touch on this. If we turn to the back of the femur, you will see this side more protruded, more rough, okay? So this one is called the intertrochanteric crest, right? Good. And then we down to the limbs, the legs here. Okay, so the tibia, patella, and the foot here. So again, this one, medial side we have the tibia, and the lateral side we have the fibula. We say that the tibia are the weight-bearing bone. The weight-bearing bone. And these tibia, no matter how big is your body size, so the anterior shaft here, still very sharp and not covered by muscles. So that's why if you get hurt right at the front, it should be very painful, huge pain, because no muscle cover on this surface. In Cantonese, we say 上穿下穿，俾人踢好痛. This one, okay. So that's why the tibia, also the layman terms is called the shin bone. So this is the shin, like a sharp edges here, okay. So yes, what else? I also submitted other images for you. This one, patella. If you are using the notes I upload during the weekend, so you may go to MFPO and have this updated image on patella, okay? So it is embedded, so the patella is embedded within the quadriceps tendons. So that's why I think it's better to let you have this image. So this is the quadriceps tendons. It is embedded within it, okay? And then, so this is the increase the leverage of the quadriceps muscle, making the knee extension more efficient, right? And one thing I need to point out is about the terminology. Remember, this is your muscle. Muscle connect to bone. We only have tendon. But this is bone, and then we down to the bone here. So this one is the ligament. So don't mix them up. Okay. So tell me, when you do the knee jet reflex, when you try to tape the knee jet, right, make the knee jet reflex, it's actually you're tapping on these patella ligament, right? Am I right? 做乜事？咪傻咗 ？Okay. Okay. Oh, just one here. As I said, the patella with the patella ligament, it's actually attached to the tibial tuberosity, right? It's the attachment site. This is the tibial tuberosity. If I have to draw, so this location here is the tibial tuberosity, right? A posterior part, okay? Posterior part, okay? This one, the posterior part here. So another thing here, the tibia and the fibula. Always remember the tibia is the medial bone, and this bone is quite different. As you can see that the proximal part is wider, right? And it forms the ankle joint, and then we also form this one is called the medial malleolus. And for the lateral leg bones here, we are referring to the fibula. So the fibula also extend even further downward here and form this distal part here. We call it the lateral malleolus. Okay. So actually, if you will see a piece of tibia in front of you, so you need to, or you have to know, because you will have one of these questions in your sport exam, I guarantee. Every year I make either one, femur or tibia. I give you a piece of bone on the table, and then I just ask you, right or left. How can you tell the story? Always the tibia form the medial malleolus. If you are given the tibia showing like this, you will see the sharp edge here. If you are given the tibia showing at the back, what you will see? So here you will see two pectoral here at the proximal end, right? And you cannot see any sharp edges. Just try it. I will show one or two of these bone, or you just go to dissection. When we do the dissection, you take a look on the skeleton, then you can see. So actually, I invite you all to feel your own leg bone. You should be able to feel what I mean, like a brace, very sharp edges on the front. Don't try to hurt yourself, okay? Okay. And at the foot here, we have 7 tarsal bones, 5 metatarsal, and 14 phalanges. So if we down to the number, what makes a difference with the upper limbs? Numbers. I'm not talking about those 六指琴more, right? Regularly speaking, right? Or we're on our majority number of bones. So here only 7 tarsal bones, right? For the upper limbs, we have 8. So where is that one? Where is that missing one? Where is that one? I don't know. But if you calculate the patella together, then we'll make up the numbers equal again. Okay, I don't know. Oh, 有問過 ChatGPT 嘅之前。But that is somehow related to the, if you believe in that way, it's something about the evolutionary things. But I can't remember the story, my old days. Okay, so this is the surface projection and the probable features of the lower bones. Okay. 咁得意嘅，點解啲嘢亂晒龍嘅呢版嘢？ Anyway, so the surface projection and probable features of the lower limb bones. So why you need to know all of these? Because these are the surface part, so very superficial part. Say for example the usage of it for you. Later on when you do the clinical assessment, the ASIS is something you cannot miss. Remember the ASIS, very important landmark. And then also this one, the greater trochanter, because it's so superficial, you will very easily to be palpate. Of course, it's the patella as well. And also, this one. And also for both the lateral and the medial malleolus, right? Okay. They are very superficial. And also this one as well, the calcaneal tuberosity. So, next week, when you do dissection, try to check your science teacher. If he or she been bedridden for long time, so there may be the pressure sores. One of the regions, one of the commonly observed sites with the pressure sore. Apart from these, where is it? It could be the PSIS as well. It could be the sacral part as well. And this one is another part, which is the calcaneal tuberosity. You will see like a big wound, right? Fascia. Let's down to fascia, okay? So the今日我啲碌屎亂晒龍嘅，點解發生咩事？ Okay, so the fascia here. So let's take a look. So fascia is is composed of loose connective tissues and fat penetrated by the nerve fibers. It's like a stocking. The ladies stocking. You know what is stocking? The絲襪啦. It's very rough and tough stocking. So it helps to increase the muscle contractile efficiency and also enhance the renal return as well. Okay, enhance the renal return as well. So we have two. The one covering the spine here, we call it the fascia lata. The fascia lata. The fascia lata. Okay. And then for the leg, the deep fascia of the leg is called the crural fascia. Okay, crural fascia. Yes, this is the crural fascia. So covering this one, lata, and this one is the crural fascia. So as you can see, the function of these, it forms the deep fascia and also it penetrates to the bone to form the septum, to form the compartment, of both the thigh and for the thigh and for the leg as well. So in either compartment we have 3. So upper limb we have 2, lower limbs we have 3. So this one referring to the anterior compartment. As you can see here, these are the septum, right? These are the septum formed by the fascia. Okay, you can feel the difference, right, when you do dissection. This one, very tough, very tough, very tough. Okay. And then in certain regions, you may see there is a thickening of these tissues, right? We will take a look. And then for the lower limb, for the leg as well. So this one, I want you guys to put a star, put a star in this anterior compartment first. This one usually is the problematic compartment. Okay, let's take a look. Okay, for the venous drainage of the lower limbs, we have a deep and we have the superficial groups. So for the deep groups, usually it follows the artery, which is the femoral artery, superior gluteal, inferior gluteal, and the obturator. And they are the major deep vein here, referring to the femoral vein. Muscular compartment of these deep veins assist the return of blood to the heart against gravity. Okay. And for the superficial one, we have two. One is called the GSV, the great saphenous vein, and the other is the small saphenous vein. Let's take a look on the arrangement. So, this one. So we have the small saphenous vein. It's running at the back of your leg, and then it will empty into the popliteal vein. But for the great saphenous vein, it's running medially along your leg and then up to the thigh, and then gradually empty into the femoral vein. Okay. So the venous drainage of the lower limbs, you have to know the location of the great saphenous vein. It is positioned immediately in front. Here. Okay. So this is the medial malleolus. So this one is running in front of your medial malleolus. Why you need to know the location of this? It actually provides a good life-saving transfusion as a site for you to do the life-saving transfusion, even in obese patients, okay, or someone with the collapsed veins, right? Okay, and also it's also located. Another way to locate it is if you put your palm 4 digits, right, medial to your patella, from the medial border of the patella, you can also find the great saphenous vein. But for this site, when you have to do injection on this site, patient may complain because it might hurt one of the nerve here is called the saphenous nerve. It's also running next to the great saphenous vein. Okay, it's quite obvious in the dissection. You can try to find it out, okay, if you want to. So this is the clinical relevance. Why we bother about the great saphenous vein? Yes. So somehow this one we use for the coronary artery bypass. Okay, for information, for you particularly, not you, for the nurses, I would say, if they may have to stand for a long time, or when you do the surgery, standing for a long time. So this great saphenous vein somehow it may have the venous problem, drainage problem, like forming this varicose vein. Okay, so that's why if it is uncontrolled, you may have to remove it as well. So if it is needed, some people may also harvest their own great saphenous vein as a graft to use it as a bypass surgery. Okay. And also, yes, there are the clinical relevance here for your information to do the emergency transfusion as well. Okay. So venous drainage, as I mentioned, is quite a common place that we will find the varicose vein, just like this. If it is not in good shape. So this is a good way, and this is a good way, okay? So that's why when your muscle squeeze, and then the blood will go up and get back to the heart. So when your muscle relax, the valve can withhold the blood. But if the valve here got some problems, cannot close properly, we call it incompetent. Okay. So the lymphatic drainage, and also big topics for you to go. Where is it? Yes, okay. So the lymphatic drainage. So the superficial inguinal nodes here, we have about 10. It forms a chain immediately below the inguinal ligament and lies along the great saphenous vein. So these nodes receive lymphatic drainage from various structures, the thigh, the neck, the foot, and also the buttock. So why I grade all these? Because these covered by Dr. Wei already. So that's why I put it there. Yeah. So the lymph nodes somehow may get swollen. This is what you can observe when you do dissection. The inguinal nodes, usually if the patient have something wrong in this area, so the lymph nodes, because they all get together here before empty into the deep inguinal nodes, so you may see these inguinal nodes get swollen, okay, quite easily. You can easily observe it, okay? So this is the same presentation for you, but give you more text, more informations. Now, I only highlight these two because these are the deep inguinal lymph nodes. That is the major station receive all the lymphatic drainage from these superficial inguinal lymph nodes. Okay, so put a star here. So this one, which is deep portion, this one, the deep inguinal lymph nodes, right, is the final collection point, right, to receive all the lymphatic drainage of the lower limbs, okay, of the lower limbs. And what you can see, right, getting bigger and bigger in size when there is infection, that's usually referring to these superficial groups here. Like here, the superficial groups, right, around 10. Arterial supply and the site of propulsion of the pulse. So this one also important. 點解我啲嘢甩咗？我想問係咪同你哋個 handout 係咪啱同一個 sequence 㗎？同一個 sequence 係咪啊？你哋下一張係咪呢張嚟嘅 ？Okay, thank you. So as I said, arterial supplies is important, right? So there are, and also we need to feel the pulse. Somehow, I give you an example here. Say if someone got problems, say diabetic patients, poor blood glucose control, so some of the tissues here is actually not receiving blood enough. If you want to check whether the circulation is of good shape, of good conditions, then you may have to find different locations to feel the pulse, okay? And this one, you will be learned in your clinical skill workshop, okay? But I will show you the location, but for the real hands-on experience, you work with your classmate, okay? Under supervision, okay? So there are 4 pulse points. As I said, the femoral pulse, but usually we will use with reference to the inguinal ligament, the midpoint. And then this one, the popliteal pulse, you have to bend the knee a little bit so that you can feel the pulse, because the popliteal artery is quite deep inside. So you have to feel in this way. And then this is the tarsal tunnel, Then you can feel the pulse here, which is the posterior tibial pulse. And then on the surface here, the dorsum, right? So here is the dorsalis pedis artery. We feel the pulse. So it will form a very important assessment of the competency of the arterial blood supply of the lower limbs, okay? And the next one here, we talk about the arterial anastomosis. Anastomosis. As I said, we need to have good anastomosis because so important because we need to have this connection between arteries. They provide alternative routes for blood flow, especially around the joints. So where vessels may be compressed or stretched during movement. Okay. So when you see the names here, it's like there are several. Trochanteric anastomosis, cruciate anastomosis. At the back of the knee, we have the genicular anastomosis. And then here we have the tarsal anastomosis. There are several of them, okay? So, so you know that around the joint, we have alternative, right? So this key, which is important to prevent ischemia in critical area, such as the hip, the knee, the ankle joint, and the foot, okay? Dermatome. I think the next question you will ask, right? Do you have to remember it, right? Yes. Because you in your clinical skill workshop, you will be asked as well. But I need to tell you that there are many overlapping areas. So what I want you to know is some of the levels here. So okay, you know the purpose, right? Is for use for assessing and diagnosing the exact level of the spinal cord or spinal nerve injury in patients, right? So there are some areas. So these areas, we call it the zones with minimal overlap. In clinical skill workshop, you will be shown how to locate it, but at least you know that we have overlapping regions. And your dermatome and my dermatome may be a little bit different, okay? So if you have to down to the assessment, so try to locate the zones with minimal overlapping. That's what I want to emphasize. Say if someone comes to you and then is suspected to have the lumbar nerve compression. Okay. So you may see that the concerned nerve root, the spinal nerve root, may be at trouble. So that's why patient may complain some tickling, numbness or weakness over the affect, say, dermatomes and or lost the reflex. We will talk about it in a minute. So this is the cutaneous innervation of the lower limbs. So showed you like different part, different names. Then you may ask, do you have to know the exact locations? The answer is yes and no. When you come to that part, if there is important issues or information I bring it up, then you have to. If not, then just leave it. Oh, one you have to know is this particular unique arrangement. This one I can now recall and tell you, okay? Okay. So originally these are to help us to understand the cause of the cutaneous, and you know that where to apply the local anesthesia to block the nerve, okay? Okay. Now again, you may ask, do you have to know the numbers? I'd rather not to answer this. Well, for some essential one, you have to. Then you may ask, what are the essential one? Okay, so you have to listen to the story then. Okay, so this one, the milestone of the lower limbs. So a milestone links a spinal nerve root level to a movement. So clinically, we test a movement and ask, like, which root level is mainly involved? That is the question, why, or rationale why we need to know the milestones. So the key point here, we usually remember for the lower limbs, we remember the milestones in pairs, not a single layers, because adjacent roots overlap most of the time. Okay, so that's why the following, I give you the 旅遊精選, okay. So the following are the very initial important part for you. If we are testing the L2, L3, we are referring to the hip flexion. And among these action provision, we talk about the prime example. Without much prime example. So I'll give you the prime example. So L2, L3, we are testing for the hip flexion. And the prime example is the iliopsoas. And it often cover the L1 and L3 as well sometimes. Okay, you would know why, because the iliopsoas is actually two muscles. They have a broad nerve input. Okay, so this gives you the ideas, but I find this one as well really good for your memorization. This one. Can you see the logic? I like this test book. So if you have the 2 feet and then you will have the 3, 4. This is a L4, 5. And then you have L2, 3, and then directly here we back down to the L4, 5. And then it will form your easy memory, I hope. This is the most interesting map to remember the milestones, okay? So the hip flexion, L2, 3. And for the hip extension, we talk about the L4, 5, okay? And then for the knee extension, L3, 4. For the knee flexion here is the L5, S1. And then for the ankle joint here, the dorsiflexion, L4, 5. And then the plantar flexion is S1, S2. Identical with the one next to it. I did my best. This is the best diagram I can find, right? So then you work out with your logic. So this one directly 2, 3, and then 4, 5. This one L3, 4, and then L5, S1. And then the dotted line here, you have to overlap with the last letter. Okay? Good. I need a break. 3 minutes, okay. I will come back, okay. So the mildtone and the dermatome is what we are trying to check, like which particular spinal nerve that may be of troubles. So that forms the foundation, okay. Okay, then we move on to the hip joint. So the hip joint, the hip joint is a synovial joint, ball and socket type, and then it is designed for stability. So it allows like flexion, extension, and also the abduction and adduction, and then medial rotation, lateral rotation, and medullary, okay, circumduction. Okay, so then now some key structures that I want to draw your attention. First thing here is we have a lunate surface. So the lunate surface is lined with articular cartilage. And also we have these, we call the transverse acetabular ligament, bridges over the acetabular notch, right? There is a notch, there is a empty part, so there is a ligaments, right, bridge over the acetabular notch. And also we have a non-articular pit here, we call it the fovea. So the fovea. And this fovea is for the ligamentum teres. This ligamentum teres is once upon a time is a small vessels, right? But when we're getting old, this one will generally like this one. This one, we talk about the ligamentum teres, and then inside it is a branch of obturator artery, the obturator artery. Usually it's not of major significance, okay? And then we have a very strong capsules, very strong fibrous capsule lined by the synovial membrane, right? So this is part of it, okay? And then we also have the type 1 cartilage, right, forming the labrum or the collar, right, so as to, like, deepens the hip joint socket, the socket. We want, so you have a shallow C, then if you have the labrum, then you have a deeper curvature to keep the head of femur, right, inside the joint cavity, okay? Okay, so this one is the, you can refer to page 31. So I say there are a strong fibrous connective tissues capsule line with the synovial membrane. What is it? This is these three ligaments here I'm referring to. So the first one here, I highlight these using the same color code. So the outer part here in the red color here is called the iliofemoral ligament, the Y-shaped ligament. So this arises from the anterior inferior iliac spine, and then it bifurcates, okay, and becomes inserted to each end of the intertrochanteric line. This is the strongest ligament in the body, the strongest one. And it checks the extension or abduction depending on the fiber bundle, okay? So second, we have this blue one here, which is the bulbofemoral ligament. Where is it? Which is in blue here. So we have the bulbofemoral ligament. So this checks hip abduction and extension. And the last one in green here, you can see it only from the back, which is the ischiofemoral ligament. So it winds around the joint, reinforces the capsule posteriorly, and checks excessive extension and internal rotation. So this is important ideas for you. So take a look. So these are all the ligaments, right? So when we are standing upright, extended hip. So all this fiber is like twisted, which means that it pushes the femoral head more firmly inside your acetabulum when you're standing upright. So it tightens the fiber and also compress both of the head of femur into the acetabulum, okay? It forms a better support. Whereas, so this is it, right, this one. Extended hip, stabilize the joint. So whereas if you are like your position now, you are flexed the hip. So when you flex the hip, right, so all these fibers here is, we call it the lats, loosen, right? So it press the femoral head less firmly into the acetabulum, allowing a greater degree of femoral mobility. So, which means that if you're standing, you can try. If you're standing upright and then you try to do your circumflexion, you only have very small angle to achieve. If you're sitting and then you can do a greater one, right? This is because you loosen all these ligaments. you can allow a greater flexibility. But here, please take note. Greater flexibility, is it good or bad? It really depends. What if you are now all driving your car, you are a driver. You're having, no, I'm not jinx you, no. In case there is a car accident, you are driving. What is your position? Some of you got the license already, right? When you're driving. 你點㗎？你會 driving 我咪咁講。Driving. And then probably we can go to this one. So this one, sorry, I jump in and out. Okay. So if you are having your the seat belt, right? So this one probably no seat belt, but even with or without seat belt, the force is from your dashboard, right, to your flexed knee. You must be flexed your knee, right, when you're driving. While you're sitting next to your friend who is a driver, then you can uphold everything, right, in whatever positions. But if you're driving, you have to flex your knee. And the force pass through the femur and then towards here. Remember this composition? The joint here of less protection when compared with the protection that can be offered when you're standing upright. Okay? So it's actually a very commonly seen injury, right? We will talk about it later. Okay, so this form the foundation. Now you should have an idea. When you're standing upright, everything pushing to the midline. Keep stabilize the hip joint so that you can stand upright, okay, without much effort, okay? Now, this is the combination. So the hip joint strength, the strength and the weakness here. Okay, let's see. So the hip is very stable because of the strong ligaments and the tight fit of the femoral head in the acetabulum. So that's why there's relatively rare to see hip dislocation, right? But whereas your upper limbs is, relatively speaking, is more easier. Take a look on the contour of the joint, okay? So, but the capsule has the weak spot here. So these weak spots are located between the ligaments here. So this is from the front view. There must be some, like in between the ligaments, right? There are some spots that is not tightly protected by the ligaments, particularly in hip replacement surgery. So you have to work with remember next time when you do dissection, if a surgeon is next to you, ask him or her to 表演, to showcase how to open the hip joint, open up the hip joint. 好好睇㗎，快啲. Open up the hip joint. Yeah. Ask him or her to perform as if it is a surgery. They will do it for sure, okay? Okay, so most of the time it will work from the posterior approach, okay? So the hip ligament must be at least partially divided, right, to implant the prosthetics, okay? So the risk of dislocation of hip replacement, after the replacement, right, will remarkably increase because you loosen the ligament and then you input the metal inside to replace the joint. So once it being separated for the in the surgery, it will become the weak spot. Okay, so the external trauma may cause this femoral head to dislocate from the acetabulum at these sites. So this is why I make a cartoon here for this year, because I think of like this dashboard injury is quite because we said that. The hip joint dislocation is not common. But in dashboard injury, it is quite common. Think about several ways to go. First, the position of the hip joint because we have a flex hip when you are driving, okay? So then, yes, and then so this will actually like increasing the chance, right, to have the hip dislocation. What if this woman is like after surgery? It could be even worse, okay? So that's what we can digest the anatomical structures with your clinical practice later on. So now we down to another question: why AVN, right? A vascular necrosis could happen after hip fracture. So we talk about hip fracture. Actually, we are referring to either the femoral head or neck fracture. But commonly, we say that it's a hip fracture, okay? So let's take a look. So we have two fractures. Actually, there are more than two, but for illustration purpose, I only pick up two here. The first one here, we call it, okay, before we down to the fracture, let's talk about the blood supply. So as I say, we have like here, we have the medial circumflex femoral artery. Medial circumflex femoral artery. Abbreviation, sometimes I just call it MCFA. Does it sound familiar to you? MCFA. One of the good things in GI. Yes, MCFA. Medium chain fatty acid, also good things, okay? MCFA, also good thing for our femoral head and neck, okay? So these, why important? Take a look. This one, it forms, okay, it supplies most of the blood to the femoral head and neck via these retinacular arteries, okay? Very important one. So this small star here showing you this is the retinacular arteries, where it supplies, it runs between the synovial and the reticular fold, and branches of the MCFA provide most of the blood to the femoral head. Remember we mentioned these small arteries as well? So this one, which is the arteries to the head of the femur, as a tabular branch of the obturator artery. Usually it only gives minor contribution, and that's it. Okay, that's it. Okay, so that is the arrangement. So let's get back to the big pictures here. So this one is our femoral artery. When it passes through, so this one is the external iliac artery. When it passes through the inguinal canal, inguinal ligament, then here it becomes the femoral artery. So the femoral artery will give a deep arteries here with a deep femoral artery, okay? And this deep one will then bifurcate or even more, okay? One branch is called the MCFA here, and the other one here is called the LCFA, the lateral circumflex femoral artery. And of particular concern of this topic, we focus on the medial circumflex femoral artery because this one, okay? So this one supplies most of the blood to the femoral head and neck, okay? So that gives you the ideas about the arterial blood supply. So then we down to the fracture site. Say, for example, if the fracture site, we call it the intertrochanteric fracture, happens along or below the intertrochanteric line, like this. You see, if this is the fracture site, can you see the MCFA is still intact? The retinacular arteries are still in good hand. So for this intertrochanteric fracture, retain blood supply to the head and neck and femur. So good chance the femur will heal. So probably for this one, you may need to put some pin to help to fix it. But you need not to replace with metal inside the joint. What if we have another one which is called the subcapital fracture, like this one. Wood. What if the fracture is in this side, right? You cut off the retinacular arteries, so the MCFA can no longer supply blood to the femur head, in particular the femur head. So that's why in the subcapital fracture, where the fibrous capsule is damaged, the blood supply to the femoral head and neck is compromised. So common site of injury in the elderly, particularly for those with osteoporosis. So because of the lack of blood supply, so the femoral head and neck will gradually die. So this is called the AVN, the avascular necrosis. Or in some textbook or in some saying, they also use the AVN, but the A stands for aseptic, not avascular. It's nothing to do with bacteria. Aseptic, avascular. Avascular and also aseptic, both A, right? Okay? Some say the aseptic one. Okay, so the AVN causes the bone of the femoral head to collapse and flatten. So this head no longer fits perfectly inside the acetabulum, and then the joints become to wear itself out, leading to osteoarthritis and arthritic pains. So that's why the location of the fracture site is really important to estimate which way of treatment the patient should be offered. Okay, so for this one, say this is the subcapital fracture. So this one, it will very likely undergo avascular necrosis. So that's why the MEDU thinks, right, the postphatic replacement of the head is needed. So this one is called the total hip replacement. Okay, and for this one, because this is the intertrochanteric fracture, you see that the ventricular arteries are still intact. So they are still in good hand, but just that out of shape. So for this one, probably they will pin some pin, well, a lot of pin inside to through the neck and head and neck of the femur, and to help in place where the plates down the lateral side of the femur to make it room for its own heal up. Okay, no need to do the total hip replacement. This one, good. So this year I updated 2 references. These 2 references are very updated, just released last year. So okay, this is an old tradition. Most of the time I will follow more, okay, more. But Gray's Anatomy for Students are also a good textbook. So they both have the e-textbook. So you got no excuse not to read textbook, okay.